Okay, so we have now the last speaker, Dr. Prangya Panda. She will be speaking on presbyopia.
Respected dignitaries and delegates, I'll be discussing about a physiological condition, presbyopia. It's not moving.
It's not moving. Just like that it is moving on slides. This one?
So emmetropia can be defined as a state of refraction when parallel rays of light coming from infinity are focused at the sensitive layer of the retina with the accommodation at rest. Now, if the light rays come close, they usually go diverge and requires more refraction for focusing. So, the mechanism by which the converging power of the eye is increased in order to focus the diverging rays coming from the near object of the retina in a bid to see clearly is accommodation. So, what are the various ways in which accommodation can be brought out? Theoretically, the eyeball can be lengthened, or the cornea can be more curved, or the lens can be moved. All these factors are not possible in human being, and only factor which is left is the change in curvature of the anterior surface of the lens. So the word presbyopia comes from the Greek word presbyopes, old man or elder, and the suffix opia means sightedness. Gradual age-related loss in the accommodative ability of the eye, leading to progressive fall in near vision. There are various theories. So Helmholtz theory, in which in the unaccommodated state, the lens is compressed by the capsules by the tension by the zonules, and contraction of the ciliary muscle causes the ciliary ring to shorten and move forward. Thus the zonules relax and the capsular tension is relieved and the lens attains a more spherical shape. Steering's theory of increased tension, increased curvature of the capsule is due to increased tension on the zonules, and contraction of the ciliary muscle pulls on the zonules directly and increases the tension on the capsule. This causes compression at the equator and bulging at the poles. All evidences, the anatomical and physiological, are against this law. Now, the Shaka's theory states the anterior and posterior zonules act like supporting ligaments of a joint while relaxed during accommodation. The equatorial zonules contract while the ciliary muscle contracts, and presbyopia develops due to increase in the equatorial diameter of the lens, which in turn decreases the perilenticular space, and ciliary spasm can no longer tense the zonules, which is supported by scleral expansion band surgery. So, the variation of accommodation with age occurs early in the life. Accommodation is 14 diopters and the near point is 7 cm. Around 36 years it is 7 diopters and the near point is 14 cm. And around 40 years it is 4 diopters and the near point is 25 cm. Around 60 years it comes to 1 diopter. So this is how the accommodation changes with age. Near work is usually around 28 to 30 centimeter away from the eye, so the actual limit of near vision is reached around 40 years. It is not that at 40 years the changes occur, it occurs starting from the very early age, but we manage to do our works within this distance of 30 centimeter. That is why the presbyopia changes occurs around 40 years. Age-related changes in the lens, which occurs a decrease in the elasticity of the lens capsule and sclerosis of the lens substance. And age-related decline in the ciliary muscle power. Difficulty occurs in near vision. Initially starts with dim light when the pupil is dilated, allowing large diffusion circles. And there are asthenopic symptoms due to fatigue of the ciliary muscles working at its maximum limit. So these are the various tests, and accommodation assessment can be done by the RF rule. So what are the basic principles of presbyopic correction? Always find out the refractive error for the distance and then correct it. Found out the presbyopic correction needed in each eye separately and add it to the distant correction. Presbyopic add prescription should leave 1/3 of the accommodation in reserve to have a comfortable near vision, and the near point should be fixed by taking due consideration of the profession of the patient and weakest convex lens with which the individual can see clearly and comfortably at the near point should be given. So presbyopia is a relative term, as I always told before. So these are the symptoms. So what are the treatment options? The optical correction can be given, convex lenses, 1/3 of the accommodation, as I told, it can be kept reserved, better to undercorrect, and intermediate distance wherever required is to be given. Single vision reading spectacles for near, double vision for near and distance, trifocals for intermediate, and also progressive lenses. So these are the various types of lenses can be given, and contact lens can also be given for presbyopia. Monovision contact lens can be a good option. Modified monovision contact lens, bifocal contact lens can be given. So one eye corrected for distance and the other eye for near. The disadvantage is the lack of binocularity and depth perception. Modified monovision, one eye is corrected for distant vision and other eye bifocal contact lens. Advantages, binocularity for distant vision will be there. And non-accommodative treatment, so one of the monovision treatment can be done. So what are the surgical procedures? The surgical procedures very nicely described by my previous speakers. So conductive keratoplasty uses radio frequency waves to heat the peripheral corneal collagen, which results in shrinkage of the peripheral and paracentral collagen, flattening of the peripheral cornea done, and stiffening of the central cornea. Usually used after 40 years, correction 1 to 4 diopters of correction. So these are the various surgeries very nicely explained by my previous speakers. So radio frequency energy is used to gently heat and shrink the corneal collagen at specific treatment points to create a band of tightening. This band reshapes and steepens the cornea to correct hypermetropia and presbyopia. So these are the various spots which can be given, at which the radio frequency waves can be given, and these are the equipments which are needed. So these things are very nicely explained by my previous speakers. Accommodative files very nicely given by. Thank you for your patient listening.
Thank you, ma'am, for the excellent talk. Any comments, questions, Dr. Ma'am? Sorry.
Ask the panel about their experience on clear lens extraction for presbyopia.
Yes, I do that now, in the sense that earlier it was considered to be sacrilege to take out a clear lens. Nowadays we have patients in their 50s coming to us with a plus 2.5 diopters, plus 3 diopter power, and they need 5.5 for distance. With the quality of multifocal lenses that are available to us, and trifocal lenses, and our experience with biometry, we go ahead and take care of these patients. Definitely, I would not do that for high myopia. Definitely, it's not because of the significant retinal complications that is there. But up to 40, it's laser vision correction. 40 to 50, it's I use presbyopic phakic intraocular lenses. And beyond 50, if it's a hyperopic patient, we do clear lens extraction. If the patient comes asking for it, it's not that if we come for glasses and plus 2, we don't go ahead and counsel them for clear lens extraction. Often sometimes the son gets a smile procedure, then the mother in the post of, what about me, can you do something for me? And if she's wearing a 2.5, the results are good. But clear lens extraction is something of a challenge both to the lens and the surgeon, because the patients are coming with good quality vision and good quantity of vision. So you have to be very thorough with your workup, look at the corneal aberrations, do an eye trace, topography, accurate biometry, but then bilaterally implanted, many of these patients are quite happy.
I think maybe women might be more accepting of it than men.
That's true, that's true. Because, you know, especially in our society, still the night vision driving requirements for, yeah.
Sai, I have a question for you. Yeah, if all other parameters are normal, what is the if the cornea is also suitable for all the procedures, which is the if the refractive power is suppose think 8 or 9, minus 8 or minus 9, and which procedure you choose, ICL or laser vision correction?
Yeah, I think that's a very important, relevant question. I mean, obviously, if there are any contraindications to what a laser vision correction, you will go for a phakic intraocular lens, whether it's a corneal curvature or topographic features or thickness. But then, even assuming that the patient absolutely ideal candidate, -8, I would still go for a phakic intraocular lens. You know, we have been doing laser vision correction for almost 2.5 decades now, and I have started believing that laser vision correction that we do has a lifetime. In the sense, even though patients have lived with a good vision for 10 years, 12 years, they've ultimately come with a -1, especially these high myopic eyes, a -1, 1.5 diopters. Fortunately, by that time, they are almost approaching 40, because of which they are more accepting of that. But if a patient is highly demanding, has a -8 diopters, cost is not a constraint, then phakic intraocular lenses maybe gives us more repeatable, longer lasting results than a laser vision correction, whether it's SMILE or whether it's PRK or anything.
And I think the quality of vision with an ICL is much better than following a laser refractive surgery. So that becomes a plus point. You'll have to weigh how much of ablation you're doing, and usually, so we have surgeons in LVP who even do -12 laser ablations. But I have a cutoff, and I think -8, maybe with a little bit of cylinder would be mine. I don't like to ablate more than 120 microns. And so I think the ICLs definitely, they give that edge. And if you have regression, you can't do anything after that. So then you can obviously put an ICL for a regression, and you have -1 or -2 diopters, you have to wear lenses, glasses or contact lenses. So I think that's a trade-off that you have to kind of deal with, and the ICLs do well in that bracket of patients. You can always do a touch-up with a laser for an ICL, but you can't do anything if you've done laser already.
And since the cost is a factor in India, not everyone can afford ICL. So the patients who are high myopes, not suitable for laser vision correction, you give the option of phakic IOLs versus the refractive lens exchange. Because the refractive lens exchange is definitely cheaper than the ICL, because the 2 IPCL or ICL goes up to 1.5 lakh, and 2 refractive lens exchange. And you explain the complication of the refractive lens exchange and the ICL, and then definitely chooses refractive lens exchange only, that undersizing, oversizing. So what we should do?
No, but I think if you weigh the fact that you do a refractive lens exchange in a young patient, okay, you may get away by putting a lens which is trifocal, or one of the CRV lenses, but you can't actually do that because of the retinal detachment risk that they run, right?
Yes.
I mean, if somebody comes with a much higher, at a much older age group, you may consider refractive lens exchange, but even then, for myopes, it's a little risky, I feel.
Yeah, vision with accommodation and without accommodation is totally different. That we need to understand. No lens, no artificial lens can match the natural lens. That company also accept, and they, at most they are matching to a aged lens, not a young crystalline lens. But always with clear lens exchange, definitely you will carry all this. Madam has mentioned, no? Yeah, retinal detachment, especially high myopes, retinal detachment, CME, all these are possibilities. Endophthalmitis, of course, it's rare, but it can happen. Then that's a problem. If you explain them clearly, even they, if they ready, then they agree, then only you can proceed.
Well, like we have, I have like 4 or 5 patients, like they came for laser vision correction because they don't know that it is up to 8 or 9. So they have -15, 20 power, They came, they want laser surgery. Then I told them, the surgery is not possible for you. Then they tell, what are the other options? So we have ICL or refractive lens exchange. So they don't want to pay more than 50,000, but they want surgery. So they definitely ICL is out of question and trifocal are also out of question. Now you have monofocal or you do ICL. ICL they don't want because they can't pay. So whether you will go for the refractive lens exchange or you defer the surgery.
Defer, don't do it. I mean,
Yeah.
I think, refractive lens exchange for a high myopia in a young patient is immediately gratifying, but in the long term can be disastrous.
Yes.
So the only place where you could consider it is in a
40.
middle-aged patient where there's a complete PVD. Because once that is there, the chances of serious retinal complication is somewhat diminished, not that it is done away. So definitely it's not an option. And when I was talking to that gentleman's question about refractive, I was talking about eye probes in the fifth and sixth decade. And he correctly put it that you can never match the natural lens with its accommodative capability.
Yeah.
So a -8 or a -10 or even a -15 coming for at least 30 years or 20s, coming for, I think you should just, that's not an option, stick to contact lenses or glasses.
Sir, I think one point. I think the Indian companies like Biotech, the lenses are actually, the cost comes down to almost the cost of the femtoLASIK. So in such patients, you can consider the Indian company lenses for this thing. So the cost RIL or IPCL or the Biotech ICL Phakic with excellent quality of vision and the results are equal on par with the Star ICL. So the cost also, both eyes, it comes down to almost, and that the cost also, it's like based on the power. If it's less than -8, it's even more cheaper. So in such patients, we can consider Indian Phakic lenses.
Yeah.
Very important point, like everything else Indian, whether it's Indian phakic intraocular lenses, Indian intraocular lenses, the quality is definitely improving. And we have no hesitation in recommending those lenses to our patients. Almost 50% of my patients get Indian lenses with good results.
Sir, one doubt I have. So when you're counseling the patients for the phakic lenses, how does your counselor do it? Like, do you give an option of saying Indian or imported, or you say Biotech and Star, or how do you counsel the patients?
We never take the company's name.
Okay.
It's just that two quality of lenses. Like, it's very much like how we counsel for India intraocular lenses.
Yeah.
Say these two options are there. We are quite comfortable implanting the Indian lenses also. We're using it 5-6 years and almost 50% of the patients get it. But if you want the very best, this is the lens with a 3-decade history. They are the originals. And if cost is not a constraint, go for the ICL. Otherwise, you won't be doing a mistake by going for these Indian lenses. And just like they opt for Indian or imported intraocular lenses, they opt for this. And we are quite happy doing both.
Yeah. Thank you, sir. Thank you, sir.
I have done all these lenses. Results are good, but the problem is with the material. I'm little skeptical about the material, hydrophilic material, right? But these especially Biotech lens and ophthalmic lenses are little thicker, and IOCare lenses is very thin. That's okay, but the problem is with the material. We don't know. Results are definitely better. They are equally good, but we need to see the long-term things.
Thank you, sir.